On behalf of all the authors, I present our diagnostic algorithm for patients with metastases to the bones. 1. Diagnosis. We need to be careful with the diagnosis of metastasis to the bone as long as it's not proven. In case of an unknown bony lesion, please stop. Think and stage, and finally act. Act safe, short, and simple. The differential diagnosis of bony lesions involves multiple myeloma or even plasmacytoma, which can be treated in curative intention. Lymphoma or leukemia, which usually doesn't need surgical therapy. Always think about bone sarcoma. A wrong surgical intervention can have devastating consequences for the patient and for the surgeon. Benign lesions and tumor-like lesions are not uncommon, especially in children. And finally, we can deal with a non-oncological disease such as chronic osteomyelitis. Is the lesion lytic, blastic, or mixed? On the right side, we see a typical mixed to blastic metastasis due to prostatic cancer. On the left side, it was thought to be due to the known prostatic cancer, but biopsy revealed a metastasis of a renal cell carcinoma that was resected several years ago. This differentiation has a profound impact on the treatment decision. Do we need a biopsy? If you have a primary cancer that is usually metastasizing to the bone, and we have bioptic, proven bone metastases, you might pass on the biopsy. Otherwise, we strongly recommend a biopsy before any treatment. Please remember that the biopsy should be performed in the same manner as is done for bone sarcoma patients. 2. Status of metastasis. If we have a solitary lesion, a complete resection may positively impact overall survival. This is especially important for renal cell carcinoma. If we have a diffuse metastasized situation, the treatment intention is palliative. It will be interesting to see how we handle oligometastatic situations to the bone in the future. We need to evaluate the visceral and/or cerebral metastases to be able to put the bony metastases in the correct context. 3. General state of health. For the activity level, we can use ECOG or Karnofsky performance status. After all, other important diagnoses must be considered. Is the patient fit for surgery? 4. Specific tumor characteristics and type of therapies considered. What is the typical behavior of the primary tumor? For example, an adenocarcinoma of the lung without driver mutations in context of bony metastases usually results in a limited life expectancy. Therefore, a simpler, less invasive, but also less durable construct is usually chosen, as you see on the compound osteosynthesis of the proximal tibia. On the other end of the scale is breast cancer, with which patients can live for many years, and therefore the selected construct should do so as well. We need to understand the biology of the metastases. Pathological fractures need more time to heal, and 50% of them never will. We also need to understand how the metastases react to the non-surgical treatment. Finally, thanks to the improved treatment of the disease, patients live much longer, and so must the construct we choose. For example, a bone metastases in renal cell cancer. Its hypervascularity is well known and better pre-treated by embolization. It is mostly osteolytic and aggressive with a high risk of fracture, up to 50%. In general, there is limited potential for the fracture to heal at a high chance of a poor response to chemo and radiotherapy. If, for example, chemotherapy is planned, we should consider stabilizing an impending fracture before starting treatment to minimize the risk of complications. 5. Life expectancy. 6 to 12 weeks is considered to be the minimum for less invasive surgery. More than 6 months is considered to be the minimum for complex reconstructions. For evaluation, it is important to consult the treating medical oncologist. Database tools such as PathFX and OptiModel can be helpful as well. 6. Imaging. We need to be sure that we have evaluated the whole body to minimize the chance of missing, for example, an impending spinal cord injury. MRI is useful for determining the local extent of the tumor, as demonstrated in the example of a pathological fracture due to a renal cell carcinoma metastasis of the proximal femur in which a complete resection followed by tumor prosthesis is planned. Last but not least, we need to have imaging of the whole bone we intend to treat. 7. Non-surgical treatment modalities and their potential response. It is very important to work in a multidisciplinary team to consider all the options for treating the bone metastasis, such as denosumab or bisphosphonate, hormone therapy, and chemotherapy. Radiation therapy is still the most used treatment option for bone metastases, but interventional therapies like radiofrequency ablation, cryoablation, or embolization are alternatives to consider. And we shouldn't forget pain medication. 8. Size and location of metastasis. We need to differentiate the locations in the body and their implications for treatment. To evaluate the cortical involvement and the involvement of weight-bearing areas brings us to number 9, the potential risk of fracture. If we only have a small risk of fracture, we don't need to think about surgical stabilization. But our treatment strategy changes in situations with impending or firm pathological fractures. 10. Surgical options. If we choose osteosynthesis, we must consider intramedullary versus extramedullary devices, local curettage, cement augmentation, and interventional therapies. If we choose resection and prosthetic reconstruction, we must consider standard arthroplasties, tumor prosthesis, or revision arthroplasty. Theoretically, we can always think about resection alone, or even amputation. Conclusion. In bone metastases, please stop, think, and stage. Finally act, but act safe, short, and simple. Always remember that bone metastases are a systemic disease. The correct diagnosis is essential, and an interdisciplinary evaluation is necessary.